My task is to present to you some considerations in order to find a way to select metastatic kidney cancer patients from the immunotherapy doublet ipilimumab plus nivolumab. These are my disclosures. And it is clear that we are living a third revolution in MRCC treatment. After the era of VEGFR TKIs and the era of immune checkpoint monotherapy, now we are entering the era of immune-based combinations. In the past 2 years, these 3 relevant papers have been published, and the data relative to each study presented at major conferences regarding the use of 3 different immune-based combinations. The combination of 2 immune checkpoint inhibitors, ipilimumab plus nivolumab, and the combination of 1 immune checkpoint inhibitor, either avelumab or pembrolizumab, together with the VEGFR TKI that is axitinib for both studies. It is clear that it is key nowadays to try to guess out how to make a choice between these treatment options. First of all, we should avoid to make direct comparisons between these 3 studies because they are extremely different in terms of immune agents used, study endpoints, primary efficacy patient population, and distribution of patients between different prognostic groups. I tried to identify possible drivers of our decisions to be used in everyday clinical practice. And I'm going to touch IMDC prognostic classes, immunological mechanisms, the shape of survival curves, complete responses, PD-L1 expression, the possibility of modulating treatment, and sequential approaches. But let's start with IMDC prognosis class. This is the study design of CheckMate 1-4. CheckMate 1-4 enrolled patients, all comers, without selecting previously for prognostic groups, but its hierarchic primary co-primary endpoints were checked in intermediate and poor risk patients. And the study succeeded since it demonstrated an overall survival benefit in patients with intermediate and poor risk features for the ipi-nivo combination as compared to the old standard of care sunitinib. The immune combo also proved able to induce higher response rates, and notably a 11% complete response rate, which is something unprecedented in kidney cancer. And despite the fact that per study design, PFS was not statistically significant, still ipi-nivo achieved a longer progression-free survival as compared to sunitinib in CheckMate 1-4. As far as good risk patients, surprisingly, the overall survival results showed no differences between the 2 treatment arms, and sunitinib outperformed the immune combo in terms of median progression-free survival, showing that the immune combo proved to be active and effective in intermediate and good risk patients, but not in intermediate and poor risk patients, but not in good risk patients. Why this? We have a tentative explanation of this feature through the results of the IMMOTION 150 trial, in which it has been demonstrated that a pro-angiogenic signature predicted the benefit of a VEGFR TKI such as sunitinib over either atezolizumab alone or a combination of atezolizumab plus bevacizumab, allowing us to discriminate between the 2 measure risk classes according to MDC, intermediate and poor risk on one side and good risk on the other side. Immunological mechanisms are also useful in order to decide which kind of treatment is the ideal one for our patients. We do know that the combination of an anti-CTLA-4 antibodies and anti-PD-1 antibodies is an ideal way to fully stimulate the immune system against the tumor. The blockade of a CTLA-4 pathway acts in the periphery within lymph nodes, whilst PD-1, PD-L1 pathway blockade occurs within the tumor microenvironment. And beyond this physical different location, it is the different population that are activated that makes the difference. We know that CTLA-4 blockade induces a proliferative signature predominantly in a subset of memory T cells, and which is all but trivial because in melanoma there was the evidence that CD8 positive effector memory T cell frequencies at the end of ipilimumab treatment positively correlated with survival, meaning that blocking CTLA-4 means the possibility of expanding a population of memory cells that could be reactivated and expanded in the case of a re-challenge with the cancer antigens against which the immune response is mounted. On the other hand, PD-1 blockade leads to changes in a number of genes implicated in cytolysis and natural killer cell function. As a whole, the concomitant inhibition of these two pathways is presently the best possible way to fully stimulate the immune system against a tumor. Now I'm going to speak a little bit about the shape of survival curves. I'm happy to recall this old sentence from the late Professor Peter de Mulder, who used to say that oncology is a matter of tails. And indeed, tails are important. As important is the shape of survival curves, especially with immune checkpoint inhibitors. These are the survival curves of the very first randomized controlled phase 3 trial conducted in melanoma, the ipilimumab trial, which resembles all the other curves that subsequently were presented and published with immunotherapy. Typically, with immunotherapy, there is no separation for the first months of treatment, but later on, separation occurs and survival impact occurs, and median overall survival is thus increased. But probably more importantly, after a few years, a survival plateau is observed, and we start to see long-term survivors, and possibly, although the follow-up of these studies is too short to tell this, possibly we are going also to select a few patients that could be cured by means of immunotherapy. So let's take a look at the cures of the 3 trials I previously mentioned. It is clear that the plateau achieved in CheckMate 1-4 is striking as compared to the other 2 studies, but we have to acknowledge the fact that the follow-up of CheckMate 1-4 is definitely longer as compared to the follow-up of the other 2 studies. So these 3 studies cannot be discriminated one from the other on the basis of this late plateau. If so, let's take a look at the heads of the curves. In CheckMate 1-4, PFS curves start separating at about 6 months, while in Keynote 4-6, curve separation appears to be anticipated by almost 3 months. As far as Javelin Renal 101, the different timing of the first disease assessment do not allow any relevant comparison. Having said that, overall, also considering the already discussed immunological mechanisms, it is reasonable, in my opinion, to assume that the late benefit, the tail of the curves, observed with ipilimumab plus nivolumab could be mainly due to the 4 ipilimumab induction doses, whilst the early PFS benefit observed in Keynote 4-6 could be realistically due to the use of axitinib. Let's move to complete responses, something that I like to call the home run attitude. It is clear once again that Ipi-Nivo, the immune doublet, is able to achieve a high percentage of complete response as compared to the other studies. All these 3 studies are able to induce complete responses in a percentage that has not seen before in the field of MRCC treatment. But still, 11% complete response rate is definitely higher as compared to 5.8 in the Pembro-Axi trial, or as compared to 4.4 in the Avelumab-Axi trial. PD-L1 expression, is it really a possible driver of our clinical decision? One would say yes, taking a look at these curves, clearly showing that progression-free survival benefit is particularly achieved in PD-L1 positive patients. But as often happens in medical oncology, this is not a good discriminant because we know that even PD-L1 negative patients may respond to immune-based therapies. So this is not the case for several different reasons. First of all, we know that PD-L1 expression can greatly vary between different sites within the same primary tumor, as well as that there is only a weak correlation between PD-L1 expression in the primary tumor and its own metastatic sites. So take a look at PD-L1 expression and study results in the 3 trials. As we can see, it is clear that PD-L1 positive patients do better, but PD-L1 negative patients may also respond, and unfortunately, at least in 2 of these trials, there were also a number of patients that were not characterized according to PD-L1 expression. And another key point that is also present in the field of urothelial cancer is, and also non-small cell lung cancer, is how to check for PD-L1 expression. Because we have 3 studies with 3 different clones of the anti-PD-L1 antibody and different ways of measuring its expression in terms of the cellular population in which PD-L1 expression is checked. So it's difficult to use PD-L1 expression as a driver for our clinical decisions. The possibility of modulating treatment could be another important topic to check in order to decide what to do. We know that it is difficult to imagine what to do in kidney cancer after using concomitantly an immune checkpoint inhibitor as well as VEGFR TKIs. The situation, if you use the immune doublet, is slightly better, and it is important also to remember that ipilimumab reinduction could be a very interesting strategy to pursue in the setting of metastatic patients, especially because, as I showed you, ipilimumab is able to expand a population of memory T cells which could be re-expanded and reactivated upon reinduction with the tumor antigens. So we have data from the melanoma setting that reinduction of ipilimumab could be useful and active, once again in melanoma patients, and presently at least 1 randomized controlled trial is underway in melanoma to test this hypothesis. Even though kidney and melanoma, although sharing some features, are completely different, then it is possible to hypothesize that reinduction of ipilimumab could be useful also in the field of metastatic kidney cancer. Another driver is the possibility of thinking from the very beginning to a cyclical approach. And indeed, despite the fact that very few prospective data are presently available in terms of agents which are active after immune-based combos, still, from a theoretical viewpoint, we can say that in this setting, after the ipi-nivo immune doublet, we can almost use everything, including axitinib, cabozantinib, the combination of lenvatinib plus everolimus and tivozanib, meaning that the first-line use of ipilimumab plus nivolumab opens you the possibility of using almost everything in a second-line setting. Of course, if these options are allowed and reimbursed in your country. We do not have any comparative data between ipi-nivo on one side and the other two immune checkpoint plus VEGFR TKI combinations. But we do have retrospective data collected by the EMDC. Of course, we should handle with care these data because they are highly biased due to the retrospective nature of this study. But still, it is intriguing, in my opinion, to check for the overall survival of first-line immune-based combinations with ipi-nivo doing better as compared to the combination of immune checkpoint inhibitor plus VEGF TKI. And probably most importantly and intriguing are these time-to-failure curves showing that a second-line VEGFR TKI seems to be more active after a first-line immune doublet as compared to a first-line treatment including an immune checkpoint inhibitor plus a VEGFR TKI. So in conclusion, the ipi-nivo immune combo has a very strong immunological rationale. And according to the results of Checkmate 214, should be regarded as a present standard of care, at least in patients from intermediate or poor IMDC risk groups, but not in good risk patients who are more prone to respond to VEGFR inhibition. The ipi-nivo immune combo is able to induce a long-term survival plateau in around 30% of patients, as well as the highest complete response rate ever observed in MRCC. PD-L1 expression at present should not be used for decision-making. And we are going to listen from Tony about how to improve the possibility of selecting patients from PD-L1 expression. Ipilimumab reinduction at progression seems a reasonable strategy to pursue, especially when progression is observed during the maintenance nivolumab monotherapy phase. And finally, upon failure of the immune combo, we can use almost every available non-immunological agent with a high chances of achieving further benefit. Thank you very much for your attention.